Assalamu alaikum people. Today we'll be discussing splenic trauma. The word spleen comes from the ancient Greek splen and is the idiomatic equivalent of the heart in English. In other words, to be good spleened, eusplanchnos, means to be good-hearted or compassionate. And this fellow just broke his. A 35-year-old male passenger was in a high-speed motor vehicle collision. His vital signs are a blood pressure of 105 by 80 millimeters of mercury, a heart rate of 110, and a respiratory rate of 18 per minute. His GCS is 15. The patient is complaining of pain in the chest, abdomen, and pelvis. Now, the assessment of circulation during the primary survey includes early evaluation of the possibility of hemorrhage in the abdomen and pelvis in any patient who has sustained blunt torso trauma. Unrecognized abdominal and pelvic injury continues to be a cause of preventable death after truncal trauma. A patient who has sustained a significant blunt torso injury must be considered to have an abdominal visceral, vascular, or pelvic injury until proven otherwise. Although protected under the bony rib cage, the spleen remains the most commonly affected organ in blunt injury to the abdomen in all age groups. Injury due to rapid dislocation, such as occurs in motor vehicle crashes, direct blows to the abdomen in domestic violence, or leisure and play activities such as bicycling, frequently result in a variety of splenic injuries. It is more commonly injured in the younger population when dangerous activities rarely start. Penetrating trauma can also result in splenic injury, but is less common due to the relatively smaller size of the organ. Road traffic accident victims frequently have associated head injuries, which make diagnosis difficult and results in poorer outcomes. A delay in recognizing intra-abdominal injury can lead to early death from hemorrhage or delayed death from visceral injury. The visceral injury causes peritonitis and delayed death. Now, special populations need a higher index of suspicion. Pediatric patients may have significant intra-abdominal injury without outward signs of trauma. Trauma to the left chest or abdomen should arouse suspicion of splenic injury. This more so when there are signs of blood loss such as tachycardia, a narrow pulse pressure, tachypnea, and cold skin. Remember that younger patients become hypotensive very late. In stable patients, pain in head zone of the spleen or left shoulder pain carrier sign should raise the suspicion of a splenic injury. Multiple left lower rib fractures may be associated with an injured spleen. The presence of fractured ribs in pediatric patients particularly is ominous, since it takes a lot of force to fracture those compliant pediatric ribs. Some patients may not have any warning signs and may present days later with sudden vascular collapse. Continuing with our scenario, the patient has left-sided lower chest tenderness with abrasions of his left chest, left abdomen, and left flank. He is tender in the left upper quadrant and has pain with pelvic rock. His pelvis is stable. Significant blood loss can be present in the abdominal cavity without any dramatic changes in appearance or dimensions and without obvious signs of peritoneal irritation. So how does one know if shock is the result of an intra-abdominal or pelvic injury? In hypotensive patients, the goal is to rapidly determine if an abdominal or pelvic injury is present and whether it is the cause of hypotension. The patient history may predict, and the physical exam, along with rapidly available diagnostic tools, may confirm the presence of abdominal and pelvic injuries that require urgent hemorrhage control. Hemodynamically normal patients without signs of peritonitis may undergo a more detailed evaluation to determine whether specific injuries that can cause delayed morbidity and mortality are present. This may include repeated examination to determine whether signs of bleeding or peritonitis develop over time. Now, how do you determine if there is an abdominal or pelvic injury? The abdominal examination should be conducted in a meticulous, systematic fashion in the standard sequence: look, listen, and feel. You feel by percussion and palpation. You look for signs of peritoneal irritation, bruising over the left upper quadrant, Cahir sign, and a hypotension with tachycardia without a known source. So if a patient has fractures of the long limbs or he's bleeding severely from the scalp injury, we do know that there's another known source. Now, difficulty arises in patients with head injury, spinal cord injuries, and with alcohol or substance abuse because of the diminished abdominal signs. In patients with hemodynamic abnormalities, rapid evaluation is necessary. This can be done either with a fast scan or DPL. The only contraindication to performing these studies is an existing indication for a laparotomy. For example, a patient who has a wound and you can see the bowels are hanging out of it, he needs a laparotomy. We're not going to be doing any fast scan or anything of that sort. Of the two methods of rapidly detecting hemorrhage, DPL has a longer history. First introduced by Root in 1965, DPL involves placing a catheter in the peritoneal cavity by either a closed or an open method and aspirating any blood if present. Free aspiration of blood, gastrointestinal contents, vegetable fibers, or bile through the lavage catheter in patients with hemodynamic abnormalities mandates laparotomy. If gross blood more than 10 ml or gastrointestinal contents are not aspirated, lavage is performed with 1000 ml of a warmed isotonic crystalloid solution. We use 10 ml per kg in children. After ensuring an adequate mixing of peritoneal contents with the lavage fluid by compressing the abdomen, moving the patient by log rolling, or tilting him up or down, head down, head up positions, the effluent is sent to the laboratory for quantitative analysis if gastrointestinal contents, vegetable fibers, or bile are not obviously present in the effluent. A positive test is indicated by more than 100,000 RBCs or 500 WBCs per cubic millimeter, or a gram stain with bacteria present. Only approximately 30 ml of blood is needed in the peritoneum to produce a microscopically positive DPL result. So a high WBC count is indicative of a peritoneal inflammation. The main limitations of DPL include its potential for one, iatrogenic abdominal injury, and its high sensitivity, as I said, just 30 ml, which can lead to a non-therapeutic laparotomy. For example, even a small splenic injury in a hemodynamically stable patient may be laparotomized based on a DPL result. Where ultrasound or CT scan are available, DPL is rarely used due to its invasive nature and the need for surgical expertise. But it is useful in hemodynamically stable patients where an ultrasound or a CT scan are not available, and there are places that they're not available. Now, with specific equipment and in experienced hands, ultrasound has a sensitivity, specificity, and accuracy in detecting intra-abdominal fluid comparable to DPL. The ultrasound provides a rapid, within like 3 minutes, non-invasive, accurate, and inexpensive means of diagnosing hemiperitoneum that can be repeated frequently. That's one big advantage. Ultrasound scanning can be done at the bedside, in the resuscitation room, and another big advantage, while simultaneously performing other diagnostic or therapeutics procedures like putting in IV lines, putting in a nasogastric or a catheter. It is also useful for screening for the need of a CT scan. If we have a negative scan, we do not really need to go for a CT scan, and also reduction of admissions for observations. Furthermore, ultrasound can detect one of the non-hypovolemic causes of hypertension, a pericardial tamponade. Scans are obtained in the pericardial sac, the hepatorenal fossa, the splenorenal fossa, and pelvis or pouch of Douglas. So here, 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 and here. After the initial scan is completed, we could do another scan. We could do it in 30 minutes or so. This can detect progressive hemiperitoneum. So we can see if there is a small amount of fluid, 30 minutes it's increasing, that means we need to do something about that patient. Now our patient has the fracture of the lower ribs on the left side, which is identified on the chest x-ray, and fractures of the left superior and inferior MI identified on pelvic x-ray. Because of these findings, as well as his abdominal tenderness, the patient undergoes an abdominopelvic CT scan. CT scanning is a time-consuming procedure that should be only used on hemodynamically stable patients when there is no apparent indication for an emergency laparotomy. So a patient who is hemodynamically unstable with their gross abdominal signs and symptoms of hemiperitoneum, you're going to open up the patient. The CT scan has revolutionized the management of splenic trauma. Decisions regarding conservative or non-operative management can be made confidently with a CT scan grading using the AAST splenic injury scale. A grade 1 injury is either a subcapsular hematoma, less than 10% of the surface area of the spleen, or a laceration that is 1 centimeter deep. So a 1 centimeter deep laceration, about that, and then a hematoma. Now here we see a grade 1 spleen injury in a 35-year-old male injured in an industrial accident. An axial CECT scan showed subcapsular hemorrhage here, less than 10% of the surface area. He was managed conservatively and recovered well. A grade 2 splenic injury is a subcapsular hematoma that is 10 to 50% of the surface area of the spleen, or a parenchymal one that is less than 5 centimeters in diameter. So in the parenchyma, within the parenchyma, and then a subcapsular one that is around 10 to 50%. Or it's a laceration that is 1 to 3 centimeters deep and not involving these trabecular vessels. Okay. This is a grade 2 splenic injury in a 13-year-old boy injured after a fight. Computed tomography scan showed subcapsular hematoma involving 30 to 40% of splenic surface area. Here, this one. He was managed conservatively and made an uneventful recovery. A grade 3 splenic injury is a subcapsular hematoma more than 50% of the surface area, a large one here, okay? Or a parenchymal one, which is again more than 5 centimeters in diameter, or any expanding or a ruptured hematoma. So this hematoma has ruptured. Now the importance is, because since it's ruptured, you really do not know how much the patient is bleeding. Okay, so any laceration deeper than 3 centimeters, this one here, or involving the trabecular vessels. We do know what the trabecular vessels are here, and that is also classified as a grade 3 injury. Here we have a grade 3 splenic injury in an 18-year-old boy injured when his motorcycle hit a buffalo, a common occurrence in our country. Axial contrast enhanced computer tomography scan showed a laceration at the upper pole. See, this one is the laceration here, okay? Now, grade 4 splenic injuries are lacerations that involve segmental vessels with devascularization of less than 50% of the spleen. So this one is devascularized, this portion is devascularized. A grade 4 splenic injury in a 17-year-old boy seen here. He was injured in a motor vehicle accident. Coronal reformatted computer tomography. CT scans are taken axially and have to be reformatted. Showed multiple lacerations causing major devascularization of the spleen. You can see that these areas have no contrast, and these areas do have some contrast. So in this patient, splenectomy was performed and he made a good recovery. A completely shattered spleen or hilar vascular injury with devascularization constitute a grade 5 injury. So this one is shattered all over the place, and there are breakages in the hilar vessels. Here are the breakages in the hilar vessels. Here we see a grade 5 splenic injury in an 18-year-old man after his motorbike hit a lorry. Axial contrast enhanced computer tomography scan showed a shattered spleen with a large volume hemiperitoneum, which was confirmed intraoperatively. And this here, this arrow thing, is a vascular blush. So in a vascular blush, the important thing is that this is isodense with the aorta. So look at the aorta and look at this. That's why it's called a vascular brush. The CT scan further delineates the rib fractures and pelvic fractures and shows a grade 3 moderately severe splenic injury with a small amount of free intraperitoneal fluid in our patient. The patient's blood pressure remains normal, his heart rate is 110, his base deficit is 3.2 and his lactate is 1.7, which is within normal limits. Urgent intervention in splenic injuries saves lives. For a patient with suspected intra-abdominal bleed who is hemodynamically unstable, an urgent laparotomy is mandated. Blunt abdominal trauma with hypotension with a positive FAST or clinical evidence of intraperitoneal bleeding, or blunt or penetrating abdominal trauma with a positive DPL are indications for a laparotomy. Older patients also warrant surgery earlier due to poorer outcomes associated with conservative management. This is usually associated with comorbids. Remember, prolonged hemorrhage is associated with a greater morbidity and mortality than the risk associated with a negative laparotomy. So most of us don't want to do a negative laparotomy, but it's better to be open, see and save than not to open and be sorry. Now, trauma surgery is a highly charged discipline. Often the surgeon is fighting against time to try to save a life. A midline incision can be made rapidly and allows access to the whole abdomen by simple upwards or downwards extensions as needed. So you can go up here, you can go down here. A left subcostal incision that we can see here is used mainly in elective splenic surgery. Just a reminder of the relevant anatomy. The blood vessels that need to be taken care of include the short gastric and splenic vessels. The ligaments that need division include the splenocolic and the phrenosplenic ones. So this one here and this one here. Once the abdomen has been cleared of blood and clots, the spleen is mobilized after packing off the bowel. The incision begins at the phrenocolic ligament, and then the spleen is retracted medially by the left hand of the surgeon, and the posterior layer of the linorenal ligament is excised. Here we can see we are incising this. With continued tension, the deeper layers of the connective tissue are taken out. The posterior pancreas complex, which contains the pancreas and the splenic vessels are mobilized off the retroperitoneum. The left upper quadrant is then packed off, and the spleen is interiorized into the wound, and it is further examined and further action is decided upon. The decision to perform a splenectomy or splenic preservation depends on multiple factors. The grade of the splenic injury is an important factor. An unstable patient cannot tolerate prolonged surgery. Other life-threatening conditions such as a liver injury may force a splenectomy. Once the decision is made to perform a splenectomy, the short gastric vessels are divided and the splenic vessels are dissected off the tail of the pancreas and ligated. Until the 1970s, splenectomy was considered mandatory for all splenic injuries. Recognition of the immune function of the spleen refocused efforts on operative splenic salvage in the 1980s. Preserving the spleen prevents opsy, which we discussed in the first spleen lecture. A splenectomy leaves a potential dead space in the left upper quadrant with the risk of a subphrenic abscess formation. There also has been a steady decrease in the splenorrhaphies with the availability of a CT grading of splenic injuries and increasing non-operative management. Options of repairing a spleen are many and include hemostatic agents, fibrin glue, suture repairs, platelets to prevent suture cut through. Here we can see we've applied these platelets, okay, so that the sutures do not cut through. Suture repair augmented by an overlay of the omentum to prevent suture cut through. You can appreciate the laceration is horizontal and does not traverse more than one segment of the spleen. A resorbable mesh is used to tamponade this spleen in high grade injuries. So this is this resorbable mesh here, okay, and a sectional debridement is possible for polar injuries, poles being so one or the other pole. Okay. This technique takes advantage of the segmental nature of the blood supply. So here we are doing a sectional anatomy. At least 25% of the spleen is needed to maintain immunocompetence. When splenectomy is performed, autotransplantation is the only method to preserve splenic function. In the trauma setting, under ideal circumstances of an isolated splenic injury requiring a splenectomy, autotransplantation of the splenic implants in the omentum can achieve partial immunocompetency. Mainly, we were concerned in the younger patients. If there are associated enteric injuries, these preclude the procedure. Another technique is to take a slice of the spleen transplanted in the greater omentum and position it within the native left hypochondrium. Here you can appreciate that this is these are these portions, and this omentum is folded over and like this, so there are pockets of this splenic tissue in the omentum. The trend in management of splenic injury continues to favor non-operative or conservative management. We are trying to go as high as grade 3 and 4. This varies from institution to institution, but usually includes those patients with stable hemodynamic signs, stable hemoglobin levels over 12 to 48 hours, minimal transfusion requirements like 2 units or less, and CT scan grade injury scale grades of 1 or 2 without a blush, and patients younger than 55 years old. Up to 15 to 20% of patients with spleen traumas warrant early splenectomy, and that failure of non-operative management often represents an inappropriate patient selection. So you have to be careful in patient selection. When angiography is employed, there is a 5% failure rate for non-operative management. So angioembolization improves outcomes. Due to the fears of a delayed rupture, follow-up CT scans in high-grade injuries to evaluate for blush, often not seen on the original CT scan, are needed. Here in this CT scan, you can see the blush. This is the blush here. These delayed patients can present as late as 9 days after the injury. Higher grade injuries such as grade 4 and 5 have shown a failure rate varying from 33 to 75%. Selective angioembolization is warranted in high grade injuries with a contrast blush. These are the pre and post embolization angiograms. Here you can see the blush here, and post embolization we cannot see anything. So in summary, a hemodynamically patient undergoes a CECT, and if no blush is seen, he or she is observed with a repeat CT at 24 to 40 hours if the condition worsens. Okay, if the condition worsens. If a repeat CT scan at this time does not show a blush in the patient is further observed. If on the initial or delayed CT scan there is a blush, okay, so here we could do an angioembolization if we have that. A failed angioembolization or worsening condition of a patient warrant surgery. We did discuss complications in the first lecture, but just a reminder that this is no simple surgery. Okay. So our patient is admitted to the intensive care unit for monitoring, pain control, and respiratory care. Remember, respiratory care is an important aspect of patients' care in those patients who have lower chest injuries, rib fractures. So this patient had wrist fracture, so he needed respiratory care. His hemodynamics remain normal for 24 hours, and after which he is transferred to the ward. He is discharged on hospital day 5. So this brings us to the conclusion of this lecture on the splenic trauma. As always, it has been an enjoyable experience for me, and I hope you too enjoyed the lecture and learned something. If there are any questions, give me a shout. Allah Hafiz and stay safe.